Hello and welcome everybody. Thank you for joining with me today in another short lecture. This is Dr. Amrit and you are watching the Inside Clinic lectures. So today we are discussing internuclear ophthalmoplegia. The internuclear ophthalmoplegia, which is also called the INO, is a disorder of the conjugate lateral gaze, in which the affected eye shows impairment of the adduction. Now, what is meant by the conjugate lateral gaze? So, basically, whenever the eyes are looking towards the same side, it is called conjugate eye movements. And for the conjugate right and for the conjugate left eye movements, we have a center in the brain which is called the horizontal gaze center. Before we really dig into the internal nuclear ophthalmoplegia, it is very important to understand a few aspects about how the conjugate gaze to one side actually initiates and then propagates. The frontal eye fields give commands for the gaze in the contralateral direction. So, what I mean to say is that if there is a right frontal field area, it gives command to look towards the left side, whereas the left frontal eye field will give commands for the right gaze. So, as the command is initiated by the frontal eye field, the eyes will move towards the right side. That means your right eye looks towards the right side and the left eye looks towards the right side, and this is the right conjugate gaze. If that point is clear, let's move ahead further in the pathway of the conjugate gaze. Let me clarify at this point that we are talking about the horizontal conjugate gazes, as the vertical conjugate gaze again has a different pathway and a different center. Let us take an example that a patient wants to look towards the left side. The command to look towards the left side shall be initiated from the right frontal eye field and then travel towards the opposite side. Let us see what happens now. Our right frontal eye field goes and stimulates the left-sided pathway. The left-sided pathway, the first part is the paramedian pontine reticular formation, also called the PPRF, and it is located in the midbrain. The PPRF next, it stimulates the sixth nerve nucleus. And as we know, the sixth nerve will go on and supply to the lateral rectus muscle. The action of the lateral rectus is abduction. That means it moves the eye towards outside, and when it does, it causes the left eye to move towards the left side. At this point, you might be thinking that what happens to the right eye? What causes the right eye to move towards the left side? Let me tell you that also. For the right eye to move towards the left side, the medial rectus should somehow receive the impulse so that the right eye can move towards the nose. And we know this action is called adduction. So what happens is that the sixth nucleus, which was stimulated by the left paramedian pontine reticular formation, as it supplies the abducens, as the abducens supplies the lateral rectus, at the same time it also sends impulse to the third nucleus. And you may ask how. The answer is through MLF, that means the medial longitudinal fasciculus. So this medial longitudinal fasciculus, it shares the impulse from the sixth nerve nucleus to the third nerve nucleus, and then the third nerve finally goes on and supplies the medial rectus, and we can look towards the left side. So as you can see, it is a medial longitudinal fasciculus which is the main link point between the sixth nerve nucleus and the third nerve nucleus, and thereby connecting the two nucleus in such a way that we can have a good amount of conjugate gaze. So it is this injury to the highly myelinated tract, that is the medial longitudinal fasciculus, that leads to the internal nuclear ophthalmoplegia. as we have already seen that MLF connects the paramedian pontine reticular formation abducens nucleus complex of the contralateral side to the oculomotor nucleus of the ipsilateral side. At this point, I would like to clarify one point to avoid confusion is that whenever the left medial longitudinal fasciculus is affected, it is called the left internal nuclear ophthalmoplegia. And whenever the right medial longitudinal fasciculus is affected, it is called the right internal nuclear ophthalmoplegia. Okay? So what happens in an internal nuclear ophthalmoplegia? There are two main things that we need to remember. Number one, there is a failure of adduction on the ipsilateral side, and there is nystagmus in the contralateral eye when the eye is abducting. Let's make it more clearer. This is the same diagram that we have seen before, and let us take an example of the left internal nuclear ophthalmoplegia. As you can remember, what I said was that whenever there is a left internal nuclear ophthalmoplegia, the defect lies in the left MLF. Okay, so when the left MLF is affected, let's see what happens. When the left MLF is affected, there is no impulse going to the third oculomotor nucleus, and therefore there is no impulse going to the medial rectus of the left eye, and therefore our left eye will not be able to adduct. That means our left eye will not be able to look towards the nose. The same thing you can see in this diagram, that the left eye is not able to move past the midline towards the nose, and this is called the defective adduction. The defective adduction is seen on the same side of the MLF injury. That means if the left-sided MLF damage is there, it is left-sided INO, and the left eye cannot move towards inside. That means there is an adduction defect on the left side. But what happens to the right eye? For the right eye to look towards the right side, the lateral rectus has to be stimulated. And as we have seen before, the right lateral rectus is getting stimulated from the sixth nerve nucleus, and this is absolutely normal. Therefore, so the right eye is able to move towards the right side. However, this eye on abduction will show nystagmus. I hope that makes it clear now. As I mentioned before, the MLF is a highly myelinated tract, and therefore the disorders of the myelin like multiple sclerosis can lead to internal nuclear ophthalmoplegia. More so in the younger patients, when they present with INO, you might want to rule out multiple sclerosis. However, in an older patient, a stroke can be the primary cause. There are basically four main things that you will ask your patient to do to actually look at the internal nuclear ophthalmoplegia. And these four questions are: kindly look straight, kindly look towards the right, kindly look towards your left, and look at your nose. Let us ask all those four questions to this patient of ours. So the first question, kindly look straight. The patient is looking straight, he's orthophoric. Now we ask the patient to look towards the left side, and the left gaze is also pretty much normal. Now let us ask the patient to look towards the right side. Uh-oh. The left eye is not able to move towards the right side. Also, the right eye has moved, however, it is showing certain oscillations. That means nystagmus. So remember what I said? Whichever eye is having difficulty in adduction, that side internal nuclear ophthalmoplegia is present. That means over here, the left eye is not able to adduct. The right eye is able to abduct with nystagmus. Therefore, this is a case of left-sided INO. But what about our fourth question? You might be wondering that why should we ask the patient to look towards the nose? The answer is to test for his convergence. A very important point to remember over here is that in the internal nuclear ophthalmoplegia, our medial rectus are normal. Therefore, when the patient is actually converging, that means looking towards the nose, our horizontal conjugate gaze pathway is not being used. There's no role of MLF. Therefore, our both the medial rectors are functioning and the patient is able to look towards the nose. That means convergence is normal. This is actually a confirmatory point when you want to diagnose internal nuclear ophthalmoplegia, and it's very important to ask this fourth question and be sure about the diagnosis. That's all I have for internal nuclear ophthalmoplegia. I hope the video was helpful to you. Kindly like and give your feedback, and you can also subscribe to the channel. Thank you. So, thank you for the patient listening. Have a nice day.